Alrighty, let's go back and talk about diabetes. And obviously this is very, very prevalent in our country. We're talking about almost 24 million children and adults in this country. I believe the cost for treating diabetes is about, yeah, there it is at the bottom, $174 billion a year, a major, major problem in this country. Okay, 73% of people with diabetes have hypertension also. It happens to be a leading cause of blindness in this country and a leading cause of kidney failure. Okay, pretty extreme stuff here. If you're talking 60 to 70% of the people have nervous system damage, as in neuropathies. They get numbness, tingling, pins and needles, and because of that peripheral neuropathy is what it's called, or neuropathy on the periphery where your nerves are literally dying, then it's also responsible for a lot of amputations, as in 60% of amputations in this country are from diabetes mellitus or mellitus patients, however you want to say that. Okay, a third of all periodontal disease, as in gum disease, increases your risk for birth defects, and you can clearly see where this is a major, major problem in the United States. Okay, well, what's really happening here is you have a problem with getting rid of the blood glucose. Okay, so you get a bunch of glucose in the blood and you can't get rid of it. Why? Well, a couple of different reasons, whether you're talking about type 1 or type 2, and we'll get to that here in a second, but let's look at the causes here. Alright, causes, that doesn't really fit well with this kind of format, but whatever. Let's start with talking about pre-diabetes. This is something that is fairly new on the scene as far as identifying pre-diabetes. It's gaining a definitely mainstream credibility here in the last few years, it seems like. But this is basically saying unless you change your ways, you're going to get diabetes. Okay, that's kind of what it says. So anything, your typical blood sugar should be, fasting blood sugar should be in between 80 and 100. Well, 126 blood sugar, fasting blood sugar level, is by definition you have diabetes. So anywhere in between 101 and 125, this you're pre-diabetic. Okay, now that means that if you don't change your ways, like I said, you are probably going to develop diabetes within 10 years. So you need to lose, some body weight here. Okay, PCOS, like I said, is also associated with diabetes, and all of these things that go along with it, the hyperlipidemia, acanthosis nigricans, that darkening of the skin. And pre-diabetic is, again, if you look at all these things, it's kind of like, again, that metabolic syndrome. Okay, and that's what they say, pre-diabetic. You're, like I said before a couple times, you need to change the lifestyle or you may end up with diabetes. Okay, all right, the two types of it that we are familiar with probably already, let's review it again. Type 1 is the kids' diabetes, insulin dependent. You need to take insulin, diabetes mellitus. It's autoimmune and it attacks the beta cells in the pancreas, and what happens here is that the beta cells produce insulin. Well, if you have your own body attacking your cells that are producing insulin, then you don't produce insulin, therefore you are dependent, insulin dependent, on taking insulin by injection for the rest of your life. Okay, they call it juvenile because that typically is found in kids somewhere around, around 12, give or take a couple years, is when they tend to discover it by simply not having enough insulin, and it causes problems that are very much identifiable as you need to get to the doctor. Okay, all right, anyway, diabetic ketoacidosis is also part of this, and another word they call it sometimes metabolic acidosis. It is the condition basically where your body is burning ketones instead of fat and making your blood levels drop, as far as your pH levels drop, as in you become more acidic. One of the buzzwords on this is fruity breath for diabetic ketoacidosis. The breath literally smells fruity. And these kids start losing weight pretty fast because, again, they're burning proteins and fats for fuel, and therefore the ketolysis they're going through, just like on the Atkins diet or something. All right. Type 2 is non-insulin dependent diabetes mellitus, even though people do take insulin sometimes for it. In theory, you really shouldn't have to, because type 2 is more the insulin resistance than the decreased production of it. Okay? Eventually, you end up with a decreased production, but the main problem starting out here is resistance. Basically, the receptors that are for insulin, you know, every hormone has a receptor for it, and the insulin receptors get downgraded or they start disappearing because there's just so much blood sugar all the time in the blood, because of the lifestyle, because of, you know, the high sugar all the time, obesity, that sort of thing. Then it just the receptors just start disappearing, so there aren't as many of them anymore. So it really doesn't matter how much insulin you have at first, you don't have the receptors. Now eventually you're stuck producing insulin too, okay, and that's when some of these people have to take insulin. But for the most part, you know, non-insulin dependent means that you don't really have to. Okay, the gestational diabetes mellitus, okay, is during pregnancy. That is when someone doesn't have diabetes, but they get it during pregnancy, and then after delivery it goes away. It's kind of like a warning sign that probably in the next couple of years you're going to get it, diabetes. So again, it's one of those, kind of like the pre-diabetes thing. It's a special warning. Okay. I have no idea why the color of that screen just changed, but moving on. Okay, most of a vast majority, 90 to 95% of diabetes cases in the U.S. are type 2 diabetes, as in the obesity-related one. It does decrease life expectancy because of a lot of different things, because of heart, kidneys, amputations, sicknesses, just a whole bunch of things. Okay, so what's happening pathologically speaking? Like I said, the insulin production decreases in, again, later. I wish I probably should have put these 1 and 2 the other way, but what's really happening here, let me start with that, in fact, with number 2, is that insulin resistance. So I already said that the receptors are being decreased, and initially your body's able to keep up by producing more insulin. Eventually you stop producing all that insulin, and the receptors gave up, and now you're not producing as much insulin anymore. These beta cells are being destroyed because of that constant sugar that literally are destroying it. Okay, you also get these amyloid plaques formation in the pancreas, and that's destroying it. Lipids are certainly not doing it any favors, and the high levels of glucose and free fatty acids are, like I said, it's also destroying the beta cells. So basically the pancreatic beta cells just kind of start breaking down. Okay, and cytokines are also destroying. So you can see where eventually, like I said, you start off the resistance, eventually you start decreasing insulin production because of all of these factors working against it. Okay, and now you're producing glucose by the liver. It's just a battle going on in there, and you know, you lose as the patient. Okay, well, color's back. How weird. Alrighty then. Diabetes. Okay, signs and symptoms, the 3 Ps. I don't know. I think somebody's kind of stretching a little bit here. Polyuria, that means you have to urinate a lot. Polydipsia, that means that you drink a lot. And polyphagia means you're thirsty a lot. Well, duh. If you're urinating a lot, you're going to be thirsty a lot, so you're going to drink a lot. Okay. Moving on. Neuropathies, as in retinopathy. I mentioned about blindness. Okay, again, you're destroying the nerves in the body from that very high sugar constantly being in the blood. It destroys the kidneys and, of course, the peripheral nerves, where you start seeing amputations, when you start seeing infections, for especially like on the well, all over the place, but at the bottom of the foot you see infections, and therefore leading to amputations, with infections going in there, getting gangrenous and that sort of thing. Urinary tract infections, yeast, things that cause infections love sugar. Okay, And I already mentioned about the periodontitis or the gingivitis, dry skin, blurred vision. Back to some of these neuropathy things here. I already talked about the acanthosis nigricans, the darkening of the skin. Skin tags, I have no idea why it is associated with that, but there you have it. Okay, I already said these about the testing, 126 for diagnosing diabetes. The hemoglobin A1C, glycolated, or I thought it was glycolated, maybe it's glycated, hemoglobin. Basically what this does is we have a problem with patients that are on controlled diets and supposed to be taking care of themselves with insulin and all sorts of things, whatever the case is. They have a treatment plan. Well, they're very good about following the doctor's advice right before doctor's appointments to get checkups. What they're not good about is in between that. So say somebody with diabetes goes in the doctor every 3 months for a checkup. A couple of days before, they're really good and their blood sugar is low, and they go into the doctor and everybody's happy. Wow, you're doing a great job. Well, what we found out is people are still getting all of these problems anyway, even though on paper it all looks good. Well, the hemoglobin A1C, what it does is, because of all the sugar in the blood, and that excess sugar goes in and literally binds to the hemoglobin in red blood cells. Well, this tests that, how much sugar is literally bound to the hemoglobin in red blood cells, and that tells you, because red blood cells last 3 to 4 months in there before they're recycled, it tells you what the average amount of sugar in that bloodstream was during the past 3 or 4 months. Okay, so they just have a what percentage, and basically what they're saying is normal, keep it under 5.7%. But what you see on these hemoglobin A1Cs for the past 3 months, overall, this person is 6.5 or higher for diabetes. Okay, this pre-diabetes again is kind of new, somewhere in between there. All right, does that make sense? So it's hard to get away with not being good all the time with the hemoglobin A1C, because now you can tell what the average was. Okay, there's a picture again of that acanthosis nigricans, that dark skin. It says zoom in on it. Okay. All right. Type 2 diabetes accounts for what percent of all diagnosed cases of diabetes in the United States? Give you a second to think about that. Okay. I believe our slide said somewhere between 95% and 98%. Okay. Did I say all undiagnosed? I hope I said all diagnosed. Anyway, the 3 basic pathologic changes causing type 2 diabetes. Okay, do you remember those 3 pathological changes causing type 2 diabetes? Give you a second to think about that. In fact, let me zoom back here while you're thinking about that. Doom, 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 doom. It's not on here. Doom, 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 doom. Whoa, back to that again. Okay, is there 1, 2, 3? Not in that order. Resistance, production decreases, and making more by liver. Do, 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 do. Back to our quiz again. 3 P's. 3 P's are easy to remember because it has to do with peeing, right? So polyuria would make you have less water, so you would be more thirsty, and therefore you would drink more, right? Polyuria, polydipsia, polyphagia. Alrighty, moving on to yet another topic here, glomerular nephritis. As it says right there, you can find that on page 750 of the 5th edition pathology text. And, well, glomerular nephritis, okay, if you look at first, it ends in an itis, and that is always an inflammation of something. Well, what's it inflammation of? Well, let me see, the glomerulus and the nephrons. Okay. So pretty straightforward as far as that goes. There are a couple of different, as far as glomerular nephritis goes, there's a whole lot of reasons where you could have this. I mean, you could have injury to the glomerulus itself. You could have immune responses. You could have ischemia, free radicals build up and destroying things, drugs, toxins. Anyway, all sorts of things. Infection, as we saw before with post-streptococcal glomerulonephritis. You can also have secondary glomerular injury where it's some other systemic disease caused it, like diabetes. Okay, also like lupus that we saw before. That's what the SLE is right here. Okay. HIV, of course, congestive heart failure. You can also cause glomerulonephritis too. All right. Well, the immune problems. This is an autoimmune disease. When we're talking about the immune problems, and that's one of the major causes of glomerulonephritis. What's really happening is you get these antigens, antibody complexes that are basically fighting, and they get deposited in the glomerulus itself, and that causes injury directly. Antibodies also react against them, against the antigens in there, and you get a little bit of battle going on, and it destroys it there, I guess is probably the easiest way to say that. You can also have non-immune injury, and those are the ones I was talking about, like ischemia or toxins or something like that. Anyway, so like I said, the antigen antibody complexes, what they do is they get deposited in that glomerular capillary wall, and that calls for complement. Well, complement comes in as part of the immune system, destroying things, and it basically breaks down the cells or lyses the cells, and that'll cause more of the immune system come in, like neutrophils and monocytes and T lymphocytes, and you get phagocytes in there, and they basically just start destroying the membrane is what's really happening here. So all these immune complexes coming in, destroying the membrane, is of course the whole problem in the first place, where now you got things leaking out of the membrane in the glomerulus, and obviously that shouldn't happen. So you get protein leaking out and blood leaking out, and you start seeing that in the urine. You have damage, so it's going to cause hypertension. There's going to be pressure problems because of how much blood that goes through that kidney, causing edema. You have less urinary output because you get huge holes, and you're getting rid of things like proteins and blood that you shouldn't be, and keeping things like blood, urea, nitrogen, and creatinine inside your blood. So it's obviously a huge problem. Okay. Buergers disease. This is not the same thing as Buergers disease that we saw a few modules ago with that basically cut off blood supply to the tips of the fingers. This is Buergers disease, or what they say is IgA nephropathy. So it's an immunoglobulin A is the problem, which it says right here, right at first. Okay, so the IgA nephropathy, what's going on here? Well, there may be a family history here of IgA nephropathy, and a vasculitis here is going on, causing this, so you get inflammation of your vascular tissues. All right, so what do we want to talk about that? It's takes a long time, I guess, to happen. All right, usually in young men, and because of the blood leaking, this is a nephron, right? Blood getting out of there, you start seeing bloody or rust-colored urine. This, problem with the nephrons here can lead to, total kidney failure, renal failure. These, of course, are how you test it. Pretty much the same thing. Urinalysis, biopsy for the definitive diagnosis, because you can see those IgA deposits. Not the same thing as the post-strep glomerulonephritis, which is what we talked about earlier with the glomerulonephritis, is one of the reasons for that. This was, that bacteria, and with post-strep glomerulonephritis, you have that sore throat, and because of that bacteria, and this is not the case. This is a more long-term kind of thing, and there's no cure for this thing either. The IgA nephropathy, that is, because IgAs are always kind of messed up. Let me see. I guess the main problem here is you're getting, it's a really thickening and fibrous glomerular basement membrane, and that's one of the major problems here because of that IgA buildup. Not really sure what I want to say after that. Yeah, duh. This is mostly, we're talking about the cause of this is a lot of times a virus will kind of kick this whole thing off too. So you start seeing symptoms after a viral infection, where this post-strep was after a bacterial infection. Not that you can necessarily tell the difference, but just one of those things we kind of mentioned in there. All right, renal failure in general. Okay, your kidneys fail. It could be because of something that's pre-renal, as in happening before the kidney, like congestive heart failure. Could be a problem with renal, like we talked about, or something post-renal. And I guess I'm probably thinking about like diabetes insipidus or SIADH or something like that. Okay, for post-renal. Signs and symptoms, same things that we were always talking about, yes? Other than, I guess we didn't really mention confusion and seizures, but these sort of things would come with that increased, BUN and creatinine, which are toxic in the blood. Okay. Test it. Technically, urine output is less than 500 milliliters. You see all these things high in the blood, which you should not. Electrolytes are usually low. And you can look at it, of course. What else? I'm not sure what else to even say about that. Wilms tumor is actually, I need to do a check here before I go any further. Where am I on this thing? Wow, I have no idea what I just did on there. How do I do back on this? Can I go back like this? Yes. Well, unfortunately I don't know how close to the end I was on that, so I'm going to break this off and start another one because this is getting pretty long.